Recording and do a little screen share with you. And this, I believe, is where we stopped last time. We were discussing Zevalin, which is an antibody that is designed to treat certain forms of non-Hodgkin's lymphoma. And today in the big chart, we're going to start with lymphoscintigraphy. I know that you're all familiar with it. And today we have two agents of choice. One is sulfur colloid, not just regular sulfur colloid that we would make or order for a liver scan, but what we call ultra-filtered colloid. And we'll talk about that more in just a moment. And the other drug is called Lymphoseek. And the beauty of Lymphoseek is that when this drug is made, particle size comes out exactly where we want it. So we don't have to be bothered with the filtration process. In both cases, we use an amount varying from about 0.5 millicurie for melanoma up to about 2 millicuries for breast cancer. So this is the filtration setup. Kind of sorry it's sideways, but I think you'll get the point. We take the sulfur colloid, put it in a 10 milliliter syringe, and we push it through one or two piggybacked filters. These two filters are 0.2 of a micrometer pore size or smaller. So what is collected in this sterile evacuated vial is clear and colorless, but the particles are there. They're just so tiny that you can't see them with your eye. It doesn't look cloudy at all like sulfur colloid typically does. Now, what are we doing in lymphoscintigraphy? We are really trying to outline for the surgeon the lymphatic drainage pattern so that the surgeon will know where to go to look for lymph nodes. So that's all that we're trying to do, outline the drainage pattern. And please note this key word right here. We're going to be doing an intradermal injection. It's not subcutaneous. It's not any other route, but intradermal. Why are we even doing this? No surgeon, I don't care how good he is, can look at a patient and say, I know what the drainage pattern is going to be. No one can do that. The first patient we ever did, which was probably 30 years ago, was a young lady who had melanoma on her back, but off the midline of her back. And the surgeon brought her down, and we did a lympho study, and we found migration to the axilla on both sides and inguinal just on one side, but not the other. No one could have predicted that. And so what we are doing here is simply guiding the surgeon as to where to go to biopsy the nodes. This is truly a lifesaver, as well as preventing biopsies that are just totally unnecessary in some places. How does it work? For melanoma, let's say the melanoma has been excised. We've waited about 7 to 10 days for it to heal up. And then we inject 5 bubbles intradermally around this lesion. Some people give 6, 5 or 6. Each one of these should be about 100 microcuries, and the volume should be 100 microliters. That means the concentration that we want ultimately would be 1 millicurie per milliliter. That would give us 100 microcuries and 100 microliters, and that's 1/10 of a milliliter. So we use a tuberculin syringe and a very tiny needle for doing the injection. And here's a pattern we might see. Here's where the lesion is. We see migration to the axilla on both sides, but inguinal only on this side, but not the other. And again, no one could have predicted that. Also, please note that when we do the injection, we typically have the patient already under the camera with the camera running, because migration is often very rapid, especially with this filtered colloid. You can start in just a few minutes. And so we often can image as early as 15 minutes. And if we were to see colloid migrating at, let's say, 75 or 90 minutes, that would be totally abnormal. For breast cancer, there are 2 ways to do the injection. We prefer the intradermal way, just like with those other procedures we just talked about. And so the breast is divided into 4 quadrants, and our physicians inject intradermally. And the alternative method is what is called a deep, or called a peritumoral injection. Now, in theory, that's the best thing to do, because you are placing the tip of the needle right at the edge of the tumor. And so that should be the best possible way to do it. The problem is that those deep injections, significant part of the time, just don't migrate at all. They sit there. So aside from having that hot spot in the breast that doesn't, it's not moving, we're going to have to wait some number of hours and then repeat the whole study with an intradermal injection, which almost never ever fails. So we have chosen, and many hospitals have chosen, not to do that peritumoral injection. That's the case where theoretically it's the best, but practically it's the worst. A couple of questions for you. Which one of the following statements regarding lympho is true? Let's just go down the list. Sulfur colloid has to be filtered with a 0.2 micrometer prior to injection. That is true. The main purpose for performing lympho is to identify pathology. That is false. Our physicians don't say there is an abnormal lymph node. That almost never happens anyway. We don't normally see enlarged lymph nodes that we could say have pathology. Remember, we're just trying to find the drainage pattern. True or false? Migration typically begins 60 to 90 minutes. We know that's false. Could begin as early as 10 or 15 minutes. The typical route is subcutaneous. That's false. We know that it has to be intradermal. Which one of the following is false? Again, we'll go down the list. There can be more than one sentinel node. That is true. Filtered colloid can be used to evaluate lymphedema. This is true. This is the case where legs are swollen and full of fluid, and we inject the sulfur colloid between the webs in the toes. Pretty painful, but it is a valuable study. Sulfur colloid prior to filtration has a particle size of 10 to 90 micrometers. That is totally false. That is the particle size range for MAA. Sulfur colloid starts out at about 0.1 to 2 micrometers, and after it's filtered, it's all less than 0.2 micrometers. So this says sulfur colloid has a particle size range after filtration of 0.2 micrometers or less. That is true. So the only false one here is choice C. That's this one that's marked false. Next is Meckel's diverticulum. This is basically gastric mucosa that's growing in the wrong place, like the intestines. We should never be seeing it there, but some people do have this. And our drug of choice is simply pertechnetate. There is no more sensitive way to diagnose this than with a pertechnetate scan. We give typically about 10 millicuries. And why did we choose pertechnetate? And the correct answer is number 4. It is known to localize in 4 places. It's in the choroid plexus, salivary glands, the thyroid, and the gastric mucosa. While this one is true, it is water soluble, it does confer a small radiation dose. That's not why we chose pertechnetate. We chose it because it goes to gastric mucosa. Next is neuroendocrine tumor therapy, and you'll see shortly that this is for very specific kinds of neuroendocrine tumors, not pheochromocytomas and paragangliomas, any of those things. The drug of choice today is what is called Lutathera. It's labeled with lutetium-177. That's one of the rare earths where it's in the 2 rows at the bottom of the periodic table. And we give 4 doses. We start out at day 0 or day 1 with 200 millicuries. And then every 2 months for another 6 months, we repeat it. So the person's going to get a total of 800 millicuries over 4 injections and over that 6-month period. This is designed to treat what are called GEP-NETs. Those are gastroenteropancreatic tumors, but NET, they're neuroendocrine tumors. This is just some medical terminology. I'm not exactly sure how we would define foregut, midgut, and hindgut, but the doctors would certainly know. This molecule has it's a very large molecule with a molecular weight up in the many hundreds. Excuse me. You'll note that lutetium is a beta minus emitter. Even if I hadn't told you that, the arrow is going from left down to right, and you can see a bunch of gammas are coming off here. And the half-life is 6.7 days, and that's good. We want a half-life in days to perform therapy so that we minimize the damage to DNA while we are performing an acceptable therapy. Next is pancreatic cancer. The only thing we really have diagnostic for pancreatic cancer today is FDG. Yes, we also have Icreoscan. This is only good, though, for islet cell carcinoma. And FDG will find any kind of pancreatic cancer. We typically give 10 to 15 millicuries. Actually, today, we'd be more likely to give 13 to 15 millicuries than 10. Why does Icreoscan localize in an islet cell carcinoma? So if you think back to the discussion last week on neuroendocrine tumors, on adrenal tumors, we said that the mechanism is called receptor binding. This drug is binding to somatostatin receptor sites that are on islet cell carcinoma, as well as a few other tumor types. So that is the actual reason. It is not an antigen-antibody reaction. It's not actively transported, and it's certainly not compartmental localization. It undergoes receptor binding. Next is a relatively new drug called DaTscan. It's labeled with F18, so of course that's going to be a positron emitter. And typically we only give about 5 millicuries because the uptake in the brain is pretty good. And this is a scan showing you that we're really trying to determine if someone has Parkinson's disease, and it's showing you the dopamine receptor uptake. It's called DAT, dopamine transport. And so here's a scan showing you on the bottom. A normal scan has a shape sort of like a comma. That's totally normal scan. And here's an abnormal scan where it looks more like a period than a comma. And that would be diagnostic of Parkinson's disease. This is not important at all, really, unless you're interested in the chemistry, but that's the molecular structure of DaTscan. Next is parathyroid imaging, and you may not be aware of this, but many years ago, we used to do a study with 2 different isotopes. We used to do a thallium scan and then follow that up with a pertechnetate scan. And I'll show you a diagram that will explain why we did that. Today, no one would do that. Everyone would use sestimibie, probably a 10 millicurie dose. And here's why the thallium was valuable, but it was really a pain in the neck to do it. Thallium and sestimibie both go to the thyroid and to the parathyroid glands. The beauty of sestimibie is after a couple of hours, it washes out. And all that's left would be parathyroid glands and adenomas if they're present. The way the thallium worked was we had to do a pertechnetate scan, which went only to the thyroid, subtract it electronically from this scan, and then what's left over is similar for both. But this was a lot of trouble, a lot of manipulation on the computer, took a lot of time, and sestimibie is probably slightly better than that and much easier and quicker to do. This is a parathyroid scan that we did. You can see it was done almost 20 years ago. And you can see a little uptake here in the salivary glands. And here is a parathyroid adenoma, pretty easy to see compared to the other side. Here, remember, you're giving Sestamibi, so you expect to see the outline of the heart right here. If you don't see that, patient has a lot bigger problems than a parathyroid adenoma. And this, of course, is the superior border of the liver. That's a very typical looking parathyroid adenoma scan. Now, the quality of scans today would probably be a little bit better than this because this equipment's almost 20 years old and scan quality has improved over the years. Next is parotid imaging, salivary glands. There's really nothing worth saying here because no one does this anymore. Up until 1985 or so, however, there was no other way to find parotid glands really and their tumors except with pertechnetate. So we were the champs back then, 30, 35 years ago, but no one would do this today. Prostate cancer, we had Prostacint, that was on the market for a while. I do believe it's gone now, but that was a very difficult study for everybody. For the patient had to be catheterized, had to do a Prostacint scan, then follow it up with a red blood pool scan and subtract that electronically from Prostacint because you didn't want to have a blood vessel coming straight at the camera that looked just like a tumor. So that was a pain in the neck to do. And today we have a terrific drug called fluciclovine, and it's also a PET agent, F18. We typically give about 10 millicuries. The trade name is called Axumin, AXUMIN. And I don't think I have, no, I don't think I have too much on fluciclovine, but Prostacint was an antigen antibody reaction because it was an antibody to prostate-specific membrane antigen. Today, we just wouldn't use that. So this is what fluciclovine looks like. It is the only molecule I have ever seen in my life that has a cyclobutane ring in it, a 4-membered square-shaped ring. It's not significant for your knowledge, really. It's a curiosity kind of thing, but it's the only cyclobutane I've seen. And this drug is used in patients who have a recurrence of prostate cancer after they have had a prostatectomy, and there should be a PSA level of 0, but they have some PSA reading. And what that implies is there is a tumor there. And this is a drug of choice to find that tumor. It's extremely sensitive. It's really looking, it's a synthetic amino acid, and it's taken up to a greater extent in not just prostate cells if they're there, but specifically prostate cancer cells. And this will show you how wonderful this scan is. You're looking here at, I think probably anterior, and I'm not sure what the views are. Maybe just different points in time. But look at how sensitive this is. It's found all these little prostate cancer tumors all over the abdomen, and even up here. It looks to me like there's something up here in the mediastinal area and possibly up in the skull. That I'm not sure about. But the scan quality is terrific, and it is a very good guide as to where the tumor is. If there's only one tumor in the whole body, you could save this guy's life by going in surgically and removing that one tumor, and then he's cured. That's a possibility. Next is spleen imaging. And I think everything that we said last week about liver scanning is pretty much applicable to spleen scanning. The drug is the same. We would use sulfur colloid for either a liver scan or a spleen scan. And in fact, today, all physicians report this as a liver spleen scan, even if it's ordered only as a spleen scan or only as a liver scan. It's always reported as liver spleen. Also, we do have an alternative. If we want to increase the uptake in the spleen relative to the liver, we could do this. We could give a dose of red blood cells that have been damaged by heating them for about 20 minutes in a 50-degree water bath. Damaged label red cells are taken up in the spleen preferentially because the spleen has a job of removing damaged cells from circulation. And so This will give you a pretty good spleen scan. The however to it is that our large field of view cameras are so good that we really don't ever need to do this. Sulfur colloid is totally fine. Now, who knows? What is the mechanism of localization of damaged red cells in the spleen called? Anyone know?
Compartmental?
So it's actually called cell sequestration. And sequestration is a process by which the spleen captures those damaged cells and just takes them out of circulation. It does that for damaged cells, whether they're radioactive or not. So that's the mechanism, cell sequestration. And you'll probably want to note the biological half-life of red cells, which is what is used, would normally be 15 to 20 hours, but the biological half-life of damaged red cells would be considerably shorter than that. Testicular torsion. I don't know if any of you have ever seen a torsion study before. This actually is a flow study. There is no uptake of protectinate in the testes. It's simply a flow study. And here's what it would look like. You'll note that you have a diagnosis 5 minutes after injection. Here is uptake in the urinary bladder. Here is a well-perfused testis. And here's one that's poorly perfused. You already know that someone surgically has to go in there and unravel the blood supply, or this guy is going to lose half of his fertility within a couple of hours. So it truly is an emergent situation. Here's a view at 10 minutes. It doesn't look very different. We don't do this anymore. Why not? Here's your question. Which imaging technique, which is done in radiology, has almost completely replaced our testicular flow study? Anyone know?
Ultrasound?
Sure, Doppler ultrasound. And I already answered this question, but I'll ask you again. Is our scan reflective of flow through the testes or uptake in the testes?
Flow. Flow.
This is a flow study. There is no uptake in the testes, but the testes are very vascular, and so we will always see them on the flow study. Next is thyroids. You might be aware that the history of nuclear medicine really started in 1945. One of the only two medical isotopes we had available back then was iodine-131. You also had p32, which could not be imaged. And so the first thing we learned how to do was to perform a thyroid uptake scan. And that was done back then with I-131, typically 5 microcuries. That's all we gave, 5 microcuries. Today, we would prefer I-123. The image quality is much better. The radiation dose is much lower, and it's very available commercially. And here, we would give 200 microcuries for an uptake only. If it's an uptake and scan, we would probably give 400 microcuries. Even today, if it's a substernal thyroid, however, we would use I-131. And that's because the sternum is so dense and it attenuates I-123 so much that this is a better choice. Now, fortunately, substernal thyroids only represent about 1% of all thyroid scans that we do. For thyroid imaging, today we would use I-123 almost exclusively, except in the case of a substernal scan. And also, there are certain times when we can use pertechnetate for doing a thyroid scan where we would give 10 millicuries. And we're going to see shortly that there's one downside to using pertechnetate. We have to be very, very careful. And you'll see what that is shortly. Okay. The mechanism of uptake for the iodide, it's I-, simple iodide ion. It's called active transport. I think I mentioned it last week, but active transport, as you'll recall, is a normally operative mechanism that's going on in the body, but here are the key words: energy dependent. What happens here? First, the iodide is trapped, then it undergoes an intermediate with what's called thyroglobulin, that's a protein in the thyroid, and then it is converted from T1 to T2 to T3 to T4. Those are 4 energy-dependent iodination steps, and ultimately it ends up as T3 and T4 in the thyroid, and these 2 chemicals here have a biological half-life that's about 3 weeks. It's really quite long. So the pharmaceuticals for active transport, it's the same mechanism, whether it's I-131 or I-123. The isotope is irrelevant. All that matters is the chemical form, which is iodide, simple iodide, like sodium or potassium iodide. So remember, active transport is the mechanism. Initially, when the patient swallows it, it goes to the thyroid. It goes to all the places also that pertechnetate goes typically, but mostly we're interested in the thyroid uptake. And in the thyroid, once it has been organified into T4, the biological half-life is a little over 3 weeks, it could be 24 days. Now, this is a thyroid scan. I don't know that you would get a question like this, but what would be your diagnosis? What do you think? Well, a normal scan would look similar to this. It might not be as intensely black as this is. So what do you think's wrong with this patient?
Hyperthyroid.
Good. So this is a hyperthyroid patient because we're seeing extremely intense uptake, but very uniform. Both lobes of the thyroid look fine. We don't see any hot spots. We don't see any cold spots. So this is simple hyperthyroidism, easily treatable with radioactive iodine. What's your diagnosis here? Now you'll note the percent uptake is 17%. That is totally normal, but this is a totally abnormal looking scan. This is not hyperthyroidism. Anybody know what that is?
Goiter?
Sorry, say it again.
Is it a goiter?
No, these are actually hot nodules. I think you may have heard of plumber's disease. That's multinodular. Actually, it is a form of a goiter. That is true. They call it a multinodular goiter. So yeah, I'll give you credit for that. But this is hot nodules, and your board question is going to be which requires. Let me jump ahead. Which requires more radioactivity to affect the cure? That first scan we looked at, which was simple Graves' disease, or the second one, the hot nodules, which is Plummer's. Which one requires more?
Plumbers.
I think I heard
Is it the
Graves.
plumbers?
So here's the answer. Graves' disease typically only takes 8 to 10 millicuries to cure it, but the hot nodules almost always require 25 or 30. And one good question is, who is more likely to require a higher dose? Who is more likely to require a higher dose, women or men?
Men.
Nobody knows why. I don't think men's thyroids are really much bigger than women's, but women typically require around 8 and men require around 10. Who is more likely to be hyperthyroid, women or men?
Women.
Women. And what's the ratio of women to men? Might surprise you, but it's very high. It's about 80-20. So if you take a look at all the hyperthyroid patients in the world, 80% of them are female. Nobody knows why, but that's just what the numbers are. Let's go back here. What thyroid disease would we miss 5% of the time if we chose pertechnetate for scanning instead of sodium iodide? So that disease would be thyroid cancer. Excuse me. when a physician is working up a patient with thyroid cancer, he or she would not use Protectinate ever, because we have what's called a discordant nodule. 5% of the time, the thyroid cancer doesn't even show up with the Protectinate. It doesn't show up as a cold spot at all. 95% it does, but you don't want to miss 1 out of 20 patients because you chose the wrong drug. And so for thyroid cancer, we always use iodide and never Protectinate because of what is called the discordant nodule. The discord is that it looks normal with Protectinate, but abnormal with iodine. What is the correct sequence? I did mention this. Let's see if you recall. What is the correct sequence for the thyroid uptake and conversion into T4? I'll let you read through these. Is it number 1, 2, 3, or 4?
Would it be 3?
Good. Number 3. First it's trapped. Then it goes through a thyroglobulin intermediate. Intermediate alone should be a clue that that's going to be the intermediate step. And ultimately it's organified into T3 and T4. So please keep this in mind. Protectinate is also trapped, but it cannot form any kind of intermediate, and it cannot be organified because it's not iodide. And in fact, the only reason it's trapped is that iodide and Protectinate both have a -1 charge, and by coincidence, they happen to have the same ionic radius. And so the thyroid is fooled, thinks it's picking up an iodide, but it's actually picking up a Protectinate. Now, you know this as a whole body scan and a whole body iodide scan, but we officially call it a whole body metastatic survey. And if you use I-131, typically going to give 10 millicuries. In our department, we have switched over to I-123, so that is now an alternative choice. And we also give about 10 millicuries of that. For thyroid therapy, and I'm just going to fly through this because we're going to have a whole lecture in about 2 weeks on therapy. But just to mention the numbers, I already told you that Graves' disease is typically 8 to 10. So where did this 15 come from? Here's the rule of thumb. If you do a thyroid therapy for any of these, not hot nodules, but Graves or cancer, if the first dose fails, the second dose is going to be 50% larger than the first. So for example, if this were 8 to 10 and it failed, then we would increase the second dose up to 12 to 15. That's 50% larger than 8 to 10. And for cancer, we would give 150 millicuries for the first dose. And if that failed, we would give 225. I saw a fascinating scan on a gentleman back when I worked at University of Illinois. That was in the late 1970s. It was a 60-year-old guy who had thyroid cancer that had spread all over his body. He had a lesion in his pelvis the size of a small grapefruit. He had lesions in his head on the optic nerve that were making him go blind. And we gave this guy 150 millicuries of iodine. We brought him back a few weeks later and we scanned him, and his scan looked exactly like the first scan. It looked like we had given him a glass of water. We then gave him 225 millicuries for a second dose. And again, we brought him back a few weeks later and we scanned him, and he had no disease left in his body. It's a perfect example of the silver bullet concept. We gave that silver bullet that was totally curative, but it took cumulatively 375 millicuries, but it cured this guy and his vision returned. The tumors didn't go away, but they were no longer functional. And so he pretty much was cured. I mean, the tumors might eventually go away, but certainly not right away, but they're just dead. They're just sitting there doing absolutely nothing. So as a rule of thumb, if the first dose fails, the second dose is going to be 50% larger than the first. Now, later on, it might be back in the therapy part, I'm going to ask you this question, but I'm going to word it differently and it's going to have a different answer. So just kind of keep that in mind. Okay. Finally, tumor imaging with FDG. We give 10 to 15 millicuries typically. And what we are looking for is hypermetabolic activity. That's all we're doing. We are imaging areas that are hypermetabolic in activity. That's, who remembers what the mechanism is? I think someone remembered from last time. What's the mechanism of uptake of FDG in tumors? Anybody?
Is it metabolic trapping?
Good. So it's called metabolic trapping. Now, here's a good board question. Is FDG a radio-labeled sugar? And the answer, believe it or not, is no, it is not. It is a radio-labeled sugar analog. Sugars, by definition, are metabolizable. This one is not. So it's a sugar analog, and it's taken up because the tumors have a higher than normal metabolic rate, and they're picking up this sugar analog, as is normal tissue, but they're picking it up much better. And so we end up with a higher ratio of activity in the tumor compared to the surrounding tissue. We will typically see some liver. Percent uptake in the tumor is usually pretty small, maybe up to 5%. And there's uptake in almost every kind of tumor imaginable. And there are two exceptions to this rule. One is prostate cancer. The insurance companies, based on a Medicare decision, will not even reimburse for FDG PET and prostate cancer because it doesn't work very well. The other example, the other case is renal cell carcinoma, these encapsulated tumors that are in the kidneys. They don't take it up either. Now, we used to wait 90 minutes post-injection. We backed up to 60 minutes just for the background to clear out. Remember, this is 90 minutes. The half-life's 110. If you wait 90 minutes, you waited almost the whole half-life. You lost probably 40 or 45% of your photons just waiting to begin the scan. So most people have settled on about 1 hour of wait, and then we image for however long that takes. And I wanted to show you the comparative structures of glucose and FDG. Please don't go memorizing these structures. That's not going to be a board question. Here's what might be. Why is glucose metabolizable and FDG is not? And we're going to see on the next slide the reason, but take a look. FDG has a closed ring structure. It's very resistant to hydrolysis. It's hard to break any of these bonds, but glucose actually has two ends sticking out. It's not a ring structure at all. So we have this end here with an aldehyde group and this end with a hydroxide group. And so watch what happens. Glucose, glucose and FDG both can go from the plasma across the cell membrane and get into the cell. They both can do that. But what happens with glucose is first phosphorylated to glucose 6-phosphate. They call it G6P, and it's further broken down in a multi-step process and ends up as carbon dioxide and water and energy. I mean, glucose is a carbohydrate. All it's got in it is carbon, hydrogen, and oxygen. It ends up as carbon dioxide and water. FDG is phosphorylated one step, and that is the end of the line. It can't go any further. It can't be metabolized. Therefore, it is stuck in the tumor and can't get out. And that's why it's called trapping, metabolic trapping. Now, this is a breast cancer patient. It's a lady who is 80 years old, and she had had surgery and chemo for breast cancer. And her doctor said, you're cured. And then he thought twice and said, maybe it's a good idea to do an FDG PET scan just as a follow-up. Maybe we missed something. And look what they got. There are, looks like 7 or 8 lesions over here on this side. These are all lymph nodes. They look totally normal on a radiograph. They had not changed size and shape at all. And here's again the beauty of molecular imaging. We are finding something that no other procedure can find. Also, I'm no expert, but it looks to me like there are a couple of slightly hot lymph nodes in the axilla on the other side. This hot spot here, of course, is the silhouette of the heart. We expect to see that. FDG goes to the heart. Heart takes it up thinking it's a sugar, although we know it's not. So here again is the beauty of molecular imaging. And this lady, in fact, was obviously not cured at all. Now, this is a summary slide. We have covered every single one of these for tumor imaging in the last several hours. And it's just to facilitate your board study. So this is every one of them and the typically administered doses across the United States, not what we use, but what most people would use. Just a few quick questions. True or false? FDG is a radiolabeled sugar.
False.
False. It's a sugar analog. It's continuously phosphorylated and converted into CO2 and water and energy. That's true. The physical half-life of F18 limits the delay, the length of delay prior to imaging to 60 to 90 minutes. That is true. We have a 110-minute half-life. And this is the one that's false. The half-life is not 55 minutes. That's just totally false. It's twice that. Next is a leg venogram. We don't do these anymore. We used to do them probably 25 years ago, and the business has been captured now by Doppler ultrasound. These venograms were literally hated by radiology residents who had to do them in the middle of the night with contrast media, and many patients had adverse reactions from the contrast media. They vomited and they fainted and they had cardiac arrhythmias and things like that. Ours never caused any of those kinds of things. We simply injected MAA into veins in both feet at the same moment and watched the flow go up the leg. And if one of them stopped here and the other one kept going, that stopping point ended up being where the blood clot was. It was very easy to find the blood clot. And also, because we put MAA in the peripheral circulation, we were also able to get a lung scan at the end if we chose to do so. But again, we don't do this anymore. The Doppler ultrasound has pretty much completely replaced that. And here, what other scan can we get with Tech MAA? That, of course, would be the lung scan. Okay, now that is the end of the big chart, but we're not finished at all with the radiopharmacy part. Any questions about the big chart before we take a specific look at PET radiopharmaceuticals? Anyone have any questions? Okay, let's take about a 20-minute look at PET pharmaceuticals, and then we'll take a short quiz on this, and then we'll keep diving a little bit deeper. This is a list of all of the positron emitters that are used in the United States. The only two that you're likely to get questions about are the last two, which is F18 in the chemical form of FDG and rubidium in the chemical form of rubidium chloride. It's really just rubidium ion. And FDG is a cyclotron product. It comes from bombarding oxygen 18 with a proton and forming F18, and out comes a neutron. But you'll recall that rubidium comes from the strontium rubidium generator. And so this is a generator produced isotope. What does PET stand for? Positron emission tomography. True or false? We are imaging those positrons that are emitted from F18. Are we imaging those positrons? Yes or no?
No, the annihilation.
No.
Totally correct. You can't image positrons for a lot of reasons, one of which is they don't escape the body. They're electrons. How far do they go? They go a few millimeters in human tissue. And anyway, a gamma camera has an aluminum cover on it. They could certainly never penetrate that. So there is no way to image positrons. And you're totally correct. We are imaging the annihilation photons that result from positron decay. And one of the nice things about PET is that we are able to measure organ function. Remember, we're not good at anatomy. We're good at function. And we're doing so while the patient is totally wide awake and comfortable and can help us out if we need to ask questions. And truly, it was a new step forward. Now, this slide's pretty old. And when I created it, maybe 15 or 20 years ago, it was a new step forward because unlike CT and some of the other radiographic procedures that only showed structure, we were able to evaluate organ function and make diagnoses that simply could not be made in other ways. And one of the nice things was that we were able to look at the entire body on one scan. You know, if they do whole body CT, first they do the head and neck, then they do the chest, then the abdomen, then the pelvis. We don't do that. We have one scan from top to bottom. And we are interested in organ function. And here's the main reason. Functional changes on a molecular level very often predate structural changes. That means that we're able to find things before the tumors or the lymph nodes have changed shape enough that a radiographer would call them abnormal. So function beats structural, not all the time, but almost all the time. So PET is actually the only modality that can image the entire body with a single pass. And it's very valuable in determining not just if a primary cancer is present, but has it metastasized to other parts of the body. So take a look at the value of PET. It's very cost effective. You know, the Medicare does not like to pay for expensive procedures. And a PET scan bills out at typically $5,000 or $6,000. It's a lot of money. Why is Medicare so willing to pay for a PET scan? Because PET scans, take a look at the bottom line down here. PET scans often help to avoid unnecessary surgeries, both diagnostic and therapeutic. You know, the physician's working up a patient says, this guy has one tumor. Maybe we're going to go in and cut it out, but let's do a PET scan. And then he finds 12 tumors, takes them off the OR schedule. That just saved Medicare or somebody, some insurance company, many tens of thousands of dollars. So it's cost effective. We can do a whole body survey. It can avoid biopsies. It can help to differentiate between a malignant tumor and radiation necrosis, because the necrosis would give you a negative uptake and the tumor would be positive. And in fact, in breast cancer, what is very common at the time of diagnosis is to do a baseline PET scan, begin the chemotherapy, and after 2 or 3 courses of chemotherapy, repeat the PET scan. If the tumor is not changed at all, the appearance of the tumor is not changed on the scan, it's time to stop that chemo and try something else. So again, Medicare is willing to pay for that because chemotherapy is extremely expensive, and to do 5 or 6 chemos where the drug is not working doesn't make any sense. And one other thing that's not on this slide, but I wanted to mention, Dr. Henke was my former chair of our department until about 10 or 15 years ago. And he told an audience, I happened to be in it, that PET scans on cancer patients affect the management of over 43% of all patients, affect their care, change the plan. And so that's an extremely high value procedure if it can improve that patient outcome 43% of the time. Now, here are some very short-lived isotopes, and they really are analogs of the elements that are in nature. What are humans made out of? We're made out of carbon and hydrogen and oxygen and nitrogen. And yes, we have a little fluoride in our bones. So these are very short-lived things. You can see half-lives are all minutes. The only one that might be hours is F-18, where it's about 1.8 or 1.9 hours or some number like that. And here's the beauty of PET pharmaceuticals. There is no pharmacological effect whatsoever. We're only injecting micrograms or maybe a milligram of the FDG molecule itself, and we don't expect it to interact. It's a fake sugar, and the degree of safety is enormous. In fact, there really are no documented adverse reactions from PET pharmaceuticals, certainly FDG, after not hundreds of thousands, but millions of injections over the last 20 years. No adverse reactions. Radiation exposure from PET scan, it's higher than most nuclear medicine procedures, but still comparable to some of them, and still well within reasonable limits of radiation dose. PET scans are often repetitive. Some people have had them every 6 months for 5 years. That's a lot of scans, a lot of radiation, but still pretty safe to do. So the underlying principle is important. I'm going to ask you about something on this slide in our quiz in just a few minutes. We want something that's going to participate in the physiological process, in the metabolic process, but we don't want it to alter the process. We want it to participate on a molecular level. And it's not likely to alter the process because we're only giving micrograms, maybe a couple hundred micrograms of the drug. It's just too small a mass to interfere, but it's not too small a mass to participate on a molecular level. So the molecules that we use for PET are typically identical to or very analogous to naturally occurring compounds. We're going to see that. For example, FDG is a very close analog of sugar. And so we are, of course, producing those functional images. Here are some of the molecules that have been investigated. Nitrogen-13 ammonia, that's a myocardial perfusion agent. F18 fluoride, it's a bone scan. Carbon-11 acetate and carbon-11 methionine have been used for prostate cancer imaging. And I can't recall what oxygen water is for, but it's also been tried. The most widely used PET pharmaceutical in the world is FDG. It's used more than all the rest of the compounds just put together. I mentioned earlier, FDG is cyclotron produced, has a half-life of 110 minutes. And you've already seen this slide. And remember, FDG has a ring structure, glucose does not. Mechanism, metabolic trapping, simply because tumors have a higher metabolic rate than normal tissue. And once this gets in there, it can't get out because it's just trapped. It reminds me of something I heard on an ad on the radio called the Roach Motel. I don't know if you've ever heard that ad or seen this, but it's a little box with bait in it and has cone-shaped holes. And these creatures go in there and they fall into the box, but they can't get out. And this sort of, it's a crude analogy, but it sort of reminded me of that. They get in, but they can't get out. Or I think the Roach Motel, they check in, but they can't check out. So the structures of FDG and glucose are so similar that there's uptake, but they're different enough that metabolism is simply not going to take place. Now, here's a whole bunch of carbon-11 compounds that have been investigated. None of them will ever be approved by the FDA. They will only be done under investigational drug exemptions because the half-lives of carbon-11 and nitrogen-13 and oxygen-15 are short. This has got a 2-minute half-life. You can't, no company could sell a drug with a 2-minute half-life. But there's a lot of them, all different kinds of molecules too. Hydroxyephedrine is a hormone. Methionine is a molecule that's in the body. Flumazenil is like a, I believe that's a fungus treatment. I'm not sure about that. Here's some other short-lived ones. Nitrogen's 10-minute half-life. Oxygen 15 is also very short. There are a lot of F18 compounds that have been investigated, and some of these are used by other countries, but not yet in the United States. So we have F18 fluoride, we have F18 FDG. We saw iodoflupane earlier, the DAT scan. This drug, fluorodopamine, is used for Parkinson's also, and there are a bunch of other things here. Epinephrine derivatives. A heptadecanoate is a long-chain fatty acid. Estradiol is a female hormone. Wabane is a cardioactive drug. And fluorometronidazole is an antifungal agent. So all kinds of molecules. Here are some other oddball isotopes. Rubidium, which of course came from the generator. Gallium-68, which also comes from a germanium-gallium generator. There's a copper and a bromine and I-124. These are just some other things. Reimbursement. I don't know how important it is for you to know this, but the FDA has to approve the drug and the procedure for which it's used. And then Medicare has to approve the use in humans, and that with a proviso that they are willing to reimburse for that procedure. And then other insurance companies will also reimburse. The bottom line is if Medicare reimburses, other insurers will do the same. So these are prerequisites: FDA and Medicare approval. So there are 3 areas of clinical utility. It's important to know what they are. Most of the time we're doing it for oncologic reasons, cancer patients. Can also use it to assess myocardial viability to determine if there's enough living heart tissue there to revascularize it with a cardiac operation where we're stripping veins out and replacing them. Also, for neurological reasons, there are certain reasons where FDG is very valuable. One of them is for epilepsy. That's a good reason. So FDG PET has been approved in the past for all of these kinds of tumors here that are listed on this slide. There are lots of them, and there even are some others today. That this is a fairly old list. I think I'm going to skip that. And I'm going to skip that. These are just CPT codes. You would never be asked about those. And so for cardiology, it's a way to help screening for arterial disease, to look for flow rates. But here's the most important thing. You're distinguishing viable from non-viable myocardium. And that lets us determine if someone is going to have a bypass operation. More CPT codes, we'll skip that. Neurology, it's valuable for looking for Alzheimer's disease, Parkinson's, Huntington's, other dementias, epilepsy, and also for grading and assessment of brain tumors to determine how malignant are they. The more malignant they are, the more uptake we normally see for the FDG. So the conclusion is that PET scanning with those pharmaceuticals is useful in these 3 major medical areas here: oncology, cardiology, neurology, and has had a very significant impact on patient care. And it's a very cost-effective way to diagnose and stage diseases. And Medicare and the other insurers are approving new uses all the time. And I put this in the slide many years ago, and it's certainly true that FDG has replaced almost all of the other tumor imaging agents, with just a couple of exceptions, like prostate cancer. Okay, any PET pharmaceutical questions from anyone before we take a little quiz? Okay, please feel free to unmute yourself and shout out an answer if you think you know. Which one of those? What does PET stand for? A, B, C, or D?
None of these.
Okay, so the correct answer is D, none of the above. And I've asked many physicians this question, and a bunch of them got this wrong because without reading carefully, they chose choice B. But it would not be proton emission tomography, it would be positron. Which one of the following isotopes cannot be used for coincidence imaging for PET scanning?
A.
Cobalt.
Hey, cobalt-57 is not a PET agent. Carbon, nitrogen, and oxygen certainly are. Okay? Which one of the following series contains only positron emitters?
C.
C.
That would be C. Sure. You know cobalt is not, so A and B can't possibly be right. None of these iodines is positron. I-124 would be, but it's not in the list. So carbon 11, nitrogen 13, rubidium. Those are choice C. Okay. I'm going to skip this question. It said which one has not been approved. That was testicular, but by now it might be approved. I'm not sure. Let's skip that. Mechanism, you already know, metabolic trapping. Most commonly used PET pharmaceutical in the world.
A.
A, FDG, good. Which statement is correct? Let's go down and say true or false for each one. FDG is the only F-18 compound ever synthesized for nuclear medicine. True or false?
False.
Totally false. There are many compounds that have been synthesized. B, many compounds have been evaluated. That is true. How about this one? Ammonia, nitrogen-13 ammonia has a better half-life than F-18 for clinical nuclear medicine usage.
False.
False.
What is the half-life of ammonia?
10 minutes.
Good, 10 minutes. So 10 minutes is not a better half-life than 110 minutes for sure. Rubidium has never been used for PET imaging. You know that's false. Rubidium is a cardiac PET imaging agent. The half-life is C, 110 minutes. For which of the following conditions does PET have great value? A or B or C or all of the above?
All of them.
All of the above, definitely. It's good for all of those. Finding primary tumors, metastatic tumors, and differentiating necrosis from tumors, okay? Which is a correct statement now about PET. Now, this is a question right off of an exam. So I'm gonna let you read through these and tell me which one of those is correct. Yes, anyone?
Is it D?
D like David. They must not alter the process. You don't want them to alter the process. You want them to have metabolic interaction. You don't want them to have metabolic changes, and you don't want them to alter the process. So this one, D, is correct. Okay. We're going to take a mental break now. Any questions about anything related to radiopharmaceuticals? Anyone? Okay, good. Then we're going to take a look now at the basic chemistry of technetium radiopharmaceuticals. If you take any vial, any freeze-dried vial of any cold kit that we use, MDP, HDP, pyrophosphate, glucoheptanate, all the hepatobiliary agents, everything but sulfur colloid, everything contains stannous chloride in the kit. What do we need it for? Stannous ion is tin chloride. Here's why we need it. Pertechnetate, yes, the technetium has a 7+ charge here, but the anion, the whole anion, has a negative charge on it. All the drugs that we use have ions that also have negative charge. Methylene diphosphonate, anything ending in 8 is going to have a negative charge. We can't bind negative pertechnetate to negative methylene diphosphonate, to negative pyrophosphate, to negative pentate, that's GTPA. We need to convert this into an electropositive form. And it's pretty easy to do with a good reducing agent like stannous. So what stannous ion does to this is that in the process, stannous ion, which is a reducing agent, is a substance oxidized. It loses 2 electrons and becomes stannic ion. But in the process, this gains 3 electrons, and this technetium 7+ becomes 4+, and the oxygen is now gone. So look what we have now. We have a cation, a 4+ charged technetium that is now easily able to bind to a negative chelating agent like methylene diphosphonate. And so if we just put pertechnetate into a vial of methylene diphosphonate with no stannous ion, absolutely nothing happens. You've got to have the stannous ion. This is then able to bind to the MDP and form a chelate. That's technetium MDP, technetium DTPA. This is called the stannous reduction method. And here's a phrase that might come back from your chemistry days. And this is called a redox reaction, a reduction oxidation reaction. Anytime you have a reduction, you will always have an oxidation, always. So your board question is, which compound is the reducing agent, which is the oxidizing agent, which is the substance reduced, which is the substance oxidized. And if you know any one of them, you know all the rest. For example, we know the stannous reduction method. If stannous is the reducing agent, protectanate has to be the oxidizing agent. And if this is a reducing agent, it has to be the substance oxidized. If this is the oxidizing agent, it has to be the substance reduced. So here is your mini reaction. This is showing you that this is going to this. And here we're losing 2 and going to this. Now, this is a gain of 3 and a loss of 2. So if we multiply this whole equation by 2, we're going to have a gain of 6. If we multiply this whole equation by 3, we're going to have a loss of 6. We have to balance those electron gains and losses before we can write this summary reaction of all of those, which you will see in a little while. Now, all of these compounds, when this technetium here binds to MDP or DTPA, they form a structure that looks like this. I'm not a very skilled artist, but hopefully that looks like a solid octahedron. It's got 8 sides to it. The metal is trapped in a cage-like structure in the middle, and there are 6 binding sites. These 4 here, 1, 2, 3, 4, are in the plane. So imagine here is a plane with a pole sticking up the middle of it. So binding sites number 5 and 6 are top and bottom, and 1, 2, 3, and 4 are in the plane. Now, 6 binding sites are always required. It doesn't matter if there are more. If something has 10 binding sites, it's only going to use 6 of them. Now, what is the difference between a radiochemical and a radiopharmaceutical? Let me tell you what they have in common, and then perhaps you could tell me what's the difference. Chemically, there is no difference. If you buy radiochemical thallium chloride and radiopharmaceutical thallium chloride, all that thallium came from the same run of the same cyclotron. The radionuclidic purity is the same. The radiochemical purity is the same. From that standpoint, there's no difference. So what are the differences between a radiopharmaceutical and a radiochemical? Now, let me ask you one question before you answer that. You know that we're permitted to inject radiopharmaceuticals. Are we permitted to inject radiochemicals? Yes or no? Anyone? So, yes, Scott? Okay, so the answer is absolutely not. A radiochemical is something that you might do research with and inject it into rabbits to see where it goes and so on. But you're not allowed to inject a radiochemical. Are radiopharmaceuticals sterile and pyrogen free? Yes, they are. Are radiochemicals sterile and pyrogen free? We don't know. We don't know. They're just chemicals. So there are lots of differences, and here's what they are. Radiopharmaceuticals, what do we know about them? They're sterile. They're pyrogen free. The FDA has determined that they are safe and efficacious to use in humans. We know that animal studies have been performed, human studies, dosimetry studies, pharmacology studies, toxicity studies. The pH is known. The isotonicity, the salt concentration is known. We even know if the components of that kit are compatible with that glass vial and that rubber stopper. We don't know any of those things for radiochemicals. That's why we are not allowed to administer a radiochemical to a human. But radiochemicals become radiopharmaceuticals after they have gone through a process that makes them sterile and pyrogen free and meets all these other requirements. So you're only permitted to administer radiopharmaceuticals. Now, what do we use them for? This, of course, diagnostic and imaging and therapy, but radiochemicals, they're really for research prior to them becoming a pharmaceutical. And also when we, in the good old days when we performed radioimmunoassays, they were the tracer in an RAA. You were allowed to pipette it into a tube, but never, ever inject it into a human. Now, there are many different methods of production of radiopharmaceuticals, and there are a lot of molecules that have been iodinated. There are multiple iodination techniques. I doubt it's important for you to even note these, but you should just know there are lots of them. Chloramine T is a very rapid but destructive method. Bolton and Hunter is a slower and very gentle method. Lactoperoxidase, electrolytic. There's something called the Hunt reagent, the Wood reagent. There's a lot of procedures. Tritium and C14 are irrelevant. Now let's look at the overall reaction of the Stannis reduction method. Here we can see that the tin lost 2 and went to tin 4, and protectantane gained 3. Now, I mentioned earlier, if we multiply this equation by 3 and this one by 2 to balance the electrons, so that we have a loss of 6 and a gain of 6, look at the overall equation. We have 2 protectantates plus 3 Stannis ions form 2 Tec 4 pluses and 3 stannic ions. And this is what we want right here. That technetium 4 plus can then bind, I don't have an equation there, but can then bind to a methylene diphosphonate, for example, and make technetium MDP. Okay, any questions about the Stannis reduction method? Okay, good. Now, we want to take a look at red cell labeling, and there are 3 generalized methods. You're probably familiar with 2 of them, would be my guess. The in vivo method is the one that we use on MUGAs predominantly, where we inject cold PYP. Then we wait 20 minutes, and then we inject protectanate. They're pretty easy to do. If you can find a vein, you can do that. The other one that you might know about is the Ultratag method. An Ultratag is a completely in vitro method where everything is done outside the body before the final injection. So we have in vivo in vivo in vitro. That means outside the body. Technically it means in glass, but outside the body. And this is completely in vitro. So here's your question. What do these terms refer to? What are we doing in vivo, followed by what are we doing in vivo? What does that term to the left of the slash mark mean in all 3 cases? What are we doing here, followed by what are we doing here? So here's the correct answer. The first thing we're doing is we are tinning the red cells in vivo. We're giving Stannis ion injection. It binds to the red cells and it just sits there. There's no free oxygen in the bloodstream. So no reduction takes place. And so the Stannis ion is injected in vivo. And then we come along 20 minutes later and the inject protectanate. And so the radial labeling takes place in vivo. In this case, we're doing this, we're tinning the red cells outside the body. We're labeling the red cells outside the body. But in all 3 cases, we're ending up with the same product, radial labeled RBCs. So this is the answer to that. The term on the left will be where we are tinning the red cells. That's out, that'll be inside or outside the body. And then where are we radial labeling, inside or outside? Now, here is how we do the in vivo in vivo. This is very simple, really. We inject 1 milligram of Stannis ion. Now, 1 milligram is put into 5 liters of blood, and that's enough tin to tin a 225-pound man or woman, either one. So we inject the Stannis ion in vivo. That's in vivo tinning. We wait to 20 minutes, and then we inject the prescribed dose of protectanate, usually 25 millicuries, in vivo. Everything was done in vivo. And then we wait 10 minutes. And here's the downside to this procedure. The expected labeling efficiency is not great. It's around 80 or 85%. But here's the good thing. The other 15 or 20% is not free tech. It's going all over the place. The other 15 or 20% is that albumin, which is a plasma protein, is labeled. And we don't mind that because plasma protein like albumin stays in the blood pool. So for a relatively short period of time, like an hour or so. And so for doing a MUGA, this is a perfectly acceptable way to go. That's what we do in our department, in vivo in vivo. The advantages to all of these procedures, every single one of them, they're all quick and simple and inexpensive. The downside for this one is that while the in vivo procedure is good for a MUGA, it is the worst possible choice for a blood pool scan. If you're looking for a GI bleed, you would never use this procedure, ever. This is only good for a MUGA. Here's the second one. This is an improvement over the first one. Starts out the same way. We give 1 milligram of stanocyne intravenously. We wait to 20 minutes, and then that permits the stanocyne to diffuse into the red cells. But now look what we do. We're not injecting protectanate into the body. We are taking some of this tinned blood out through a butterfly, draw it into a syringe containing a small amount of an anticoagulant, either heparin or what is called ACD solution. This is citrated dextrose, very good, very safe anticoagulant. So we're going to do the tinning in a syringe hooked to the patient with a butterfly. And then after about 10 minutes of waiting in that syringe and maybe occasional shaking, then we're simply going to re-inject those label cells into the patient. Now, that brought the average labeling up from about 80% to 92, consistently 91 or 92. It's certainly an improvement. Can you see the difference in the scan quality? Probably a little bit. I don't know it's a significant improvement, but it's better. And again, they're all quick, simple, and inexpensive. And the only downside to this is it takes an extra few minutes. That's not even important, really. The in vivo now this is a modification of that procedure, so it's going to start out the same way. This is a wonderful procedure for making labeling 99 to 100% consistently. We give the stanocyne intravenously. We wait to 20 minutes, but we then withdraw into a heparinized syringe or a citrated syringe the tinned blood. We inject it into a centrifuge, into a centrifuge tube called a vacutainer. We just mix it gently and we put it stopper down, upside down in a centrifuge, and we spin it down for about 5 minutes. What that does is it packs the cells up against the rubber stopper. Using a special technique, we take out a couple of milliliters of packed tinned cells through a large gauge needle, usually a 19 or an 18 gauge needle. And then we aseptically add those to a sterile evacuated vial containing 35 or 40 millicuries of protectanate. We're not going to inject that much, but we put that much in there. After 10 minutes, the reaction is gone to completion, 100% basically, and we just re-inject 25 millicuries of those cells. So this is labeling packed tinned cells following a centrifugation procedure. Again, quick, simple, and inexpensive. Yes, it takes an extra 5 minutes and you have to have a centrifuge, but hospitals have lots of centrifuges. So the last test I want to talk about is the UltraTag kit. And this is the way we would do this. It's a vial, and that vial contains about 50 micrograms of tin, not 1 or 2 milligrams, but 50 micrograms. That's enough to tin 5 or 10 milliliters of blood. So we simply take blood from the patient, anticoagulate it, and say to the patient, go away, come back in 30 minutes. We're going to do everything in vitro. We add the anticoagulated blood to the stannous compound. We incubate for about 15 minutes. Then we add 25 millicuries of protectanate and mix it up. Now watch this cool step here. We add sodium hypochlorite. What that does is it destroys any tin that is outside the red cells, but fortunately not inside the red cells. And that prevents labeling of albumin. And then we buffer it. Anybody know what household product sodium hypochlorite is? If you're a label reader, you might know. That's Clorox bleach. This is not the Clorox brand, but it's the same chemical, sodium hypochlorite. That destroys any stannocyan outside the red cells. We expect 95% or greater. We typically get 99 to 100%. And again, this is quick, simple, inexpensive, and it does not involve centrifugation at all. Very simple procedure. This is what most of the whole world uses for GI bleeding studies. Okay, I asked you this question last week. When performing red cell labeling with technetium, what molecule is labeled and what portion of the molecule is labeled? Anyone remember?
Globin.
Hemoglobin.
Good. We're labeling hemoglobin. Are we labeling heme or globin?
The globin.
Globin.
Which chain? Alpha, beta, gamma, delta.
Beta.
So here you go. We are labeling the beta globin chain on the globin in the hemoglobin. So this is the molecule, and this is the portion of the molecule that we're labeling. We can't label that heme part because there's an iron in there, and we simply can't displace it under these physiological conditions at all. It's the same mechanism, by the way, for chromium labeling of red cells. So here's a molecule. You don't need to go memorizing this molecule, but it's important for you to look at what's happening. See these 4 blue dots right here? Those are the 4 nitrogen atoms, and the heme is actually trapped right here in the center. It might be a little bit easier to look at this one. Here are the 4 nitrogens. The iron is stuck right in the center and trapped. And each of these nitrogens has an electron pair, and it's a very tight bond to that iron. So under conditions of saline, we can't displace that. So the binding takes place out here at the periphery, like where these COOH groups are located. Okay, preparation of pharmaceuticals. We have pertechnetate. We don't do any prep for that. We collect it from the generator. We might dilute it a little, but I don't call that a preparation. That's just dilution. And then we use it as is for labeling for certain kinds of scans. For sulfur colloid, this is the most complex prep that we ever have on a routine basis, and it's still pretty simple, really. It's a 3-step process. We have a vial that contains hydrochloric acid. We add to it first the pertechnetate, and then some sodium sulfate. And the order of addition is totally irrelevant. It makes no difference whatsoever because the reaction really doesn't go very well at room temperature. And that's why we have to boil it for 5 minutes. Some manufacturers require 8, but it's always 5 to 8 minutes. So we put that vial in a boiling water bath. We boil it for 5 minutes. We cool it down. We buffer it. Some manufacturers use an acetate buffer, some a phosphate buffer, but we want to get the pH up to around 5.5 to 7 because otherwise it might be a painful injection. And as it is, when we use filtered colloid for breast lymphoscintigraphy, we have to tell the patient up front, this is going to burn. You know, intravenously, we don't even notice the injection. But when you put something as hypertonic as this, look at all the salt that's in it. It's got hydrochloric acid, pertechnetate, which is in sodium chloride. It's got sodium thiosulfate. It's got sodium acetate, sodium phosphate buffer. It is just full of salt. It is very hypertonic. And that's why it burns so much with those intradermal injections. And many years ago, we used to mix lidocaine with it. And we stopped doing it after a few weeks because the patients complained it was just as painful with the lidocaine in it as without. So we just stopped using it. So this is, again, the most difficult prep we do, but everybody can do it. It's really not much to it. Preparation of some of the technetium drugs. Here are a couple that require something special. Cestamide and MAG3 require a 10-minute boil. And tetraphosmine, which is MyoView, has a longer incubation period than normal. Most drugs, the incubation period is 3 to 5 minutes. This one happens to be 20 minutes at room temperature. Other than that, the rest of these are shake and shoot kits. We take our freeze-dried vial, we add pertechnetate to it, we shake it up, we do a little quality control after 5 minutes, and it's ready to go. They call them shake and shoot. We shake the kit up, prepare it, and shoot it into the patient. And all the other tech products are made pretty much like this. Very simple. Chromium, I don't know if they'd ask you about that or not, but we can cover it in 1 minute. We take 30 milliliters of the patient's blood, that's about 1 ounce, and usually a 60 milliliter syringe. We add either ACD or heparin to it to anticoagulate it. And then we add a little bit of chromium 51 sodium chromate, maybe about 100 microcuries on the average. We mix it and incubate for 15 minutes and we're done. It's just labels in 15 minutes. Some people add ascorbic acid, that's vitamin C. That terminates the reaction and prevents the labeling from going on in the body. And here are the precautions. When you're doing cell labeling of any kind, 2 precautions. Number 1, you want to use a large gauge needle. 20 gauge is the smallest. You really would like to use a 19 gauge needle. Patients call them horse needles because they look so big. But what happens is when you draw blood into a syringe, there's turbulence in the bore of that needle. And if you pull that plunger back really fast, you're going to destroy red cells. And you don't want to do that. So number 1, we want that large needle. And number 2, we want a very slow withdrawal and a very slow injection. Otherwise, you will damage the cells. And number 1, you're going to lose some of the cells that you want. And number 2, where do damaged cells go? To the spleen. And that's not what you want. And finally, there's a category called RTU, the ready-to-use drugs. These are the products that we buy. We don't have to do anything to them at all. Thallium, gallium, xenon, iodine therapy solution, anything that you don't have to manipulate at all falls under the category of ready to use. Okay, any questions about anything we have covered? If not, the timing looks like it's perfect because we're going to finish this test on radiopharmaceuticals by 11 o'clock approximately. And then next week will be the most high yield lecture of all, which will be, I mentioned earlier, the NRC regulations and hot lab quality control. So if you have no questions, then this test has lots of questions and lots of parts. These are true, false. So let's go down the list. Sestimibie has a short biological half-life in the heart. True or false?
False.
False. It's long. It's many hours. That's why we can wait for an hour if we wanted to for the background to clear out, but it's got a long one. Let's skip tebaroxine. They're not going to ask you that. HMPAO has a long biological half-life in the brain. The curve for HMPAO in the brain and the curve for sestimibie in the heart are identical. So this is true. This does have a long biological half-life. We're going to skip D. Technetium HSA has been off the market for 20-something years. The biological half-life of thallium is less than 5 days.
False.
That is false. It's actually 10 days. And I mentioned probably last week, that's why thallium is such a good cardiac poison. It doesn't go away. We have no way to get rid of it. It's monovalent. If it were divalent or trivalent, we could use chelation therapy. That does not work for something like thallium. Okay, so there are the answers. I'm not going to read through them, but they're there for your review. Okay, there are 3 drugs on the left. We want to put in those 3 lines the letter that corresponds with its route and percentage of excretion. So number 1, DTPA. What letter do we want to put there?
F.
F, glomerular filtration. MAG3.
B.
B.
B, right? Secretion filtration ratio is 80 to 20. DMSA. Which one?
D.
Somebody said the correct answer. Choice C. This is a tubular binding agent. It's a small fraction that's secreted, but it's predominantly tubular binding. So there are your answers. Okay. Which of the following statements are incorrect? Let's just go down the list. Protectin is distributed only in the blood pool. True or false?
True.
That is totally false. There are 4 places where protectin goes. Remember, choroid plexus, salivary glands, thyroid, gastric mucosa. Lesions detected on a cerebral radionuclide angiogram, that's a fancy way of saying a brain blood flow study, show increased uptake.
False.
That is false. Lesions on a delayed brain scan show decreased uptake. That is false. And so all of those are false. Which statements are correct? Let's go down the list. Bone scanning is more sensitive than x-rays. True or false? True. Bone scanning detects metastasis prior to x-rays.
True.
True. Bone scans are less specific than x-rays.
True.
True. So choice E, all of the above are correct. Okay. The mechanism of radiopharmaceutical localization in lung scanning is
B.
B.
B. Good. Capillary blockade, also blockage is another way to say it. Okay, let's match up these procedures with those drugs. The first one is MAA. What does that match up with?
B.
B.
That matches up with B. Xenon,
A.
B.
A. Thallium,
C.
C.
D.
Pyrophosphate,
D.
D. Good. And there they are, B, A, C, and D. Okay. Mechanism of uptake of sulfur colloid in liver spleen scanning is,
B.
B.
which one is it, B?
Yeah.
Do you like C also or not? Okay.
That's not with liver spleen, right?
B is the correct answer. I just made that up. Hydrolysis of colloid particles, I don't even know what that means. It won't, but it doesn't take place. So the correct answer is B. Okay. What percent of sulfur colloid clears from the circulation following injection? And what is the half-time of clearance from the blood pool?
B.
That would be B. Good. More than 90% clears, in fact, almost all of it. And the half-time of clearance is 2.5 minutes. So good. Choice B. Number 9. Clinical indications for spleen scanning include, what do you like? A, B, C, all of them?
B.
C?
B as in boy.
B as in boy, sorry. That is the correct answer. Lung abscesses, we would not use sulfur colloid, and the half-life of chromium, we would use, half-life of RBCs, we would use chromium 51. So choice B is correct. Which of the following are suitable for thyroid imaging?
B.
I want to give you a hint.
B.
All of them except one are suitable. Which one is not suitable?
C is not.
C.
C, right? I-125 has energies of 28 and 35 keV. We can't image anything that low. So A is okay, B is okay, D is okay, but not C. Okay. Iodide uptake by the thyroid, think about doing a thyroid uptake study, may be invalidated by which of the following? Let's go down the list. Angiographic contrast media containing iodine? Yes. Yes. Propranolol, that's the same as Inderal. That's a beta blocker. The answer is no. That beta blocker is not a problem. thyroid hormone ingestion, like
Yeah.
consuming T3 and T4 in Synthroid. That's a big problem. If someone's on Synthroid or any kind of thyroid hormone, we don't even attempt to do an uptake test because we know it's going to give either a 0 or a very low reading. So A and C are things that invalidate it. So choice D would be correct. Okay. Which one of those would be a normal range for a thyroid uptake of I-131 or I-123?
B.
B. So 7 to 30% is a normal range. Now, other hospitals use other numbers. So what you're going to see is 7 to 8% on the low end and 30 to 35 on the high end. Anything above 35% is abnormal. Right? Okay. Which of the following tech drugs are suitable for blood pool scanning?
C.
C.
Okay, that would be C only. None of these others would work. So choice C. Okay. Thallium. This is right off an old exam. Thallium is a useful cardiac imaging agent for perfusion because of the following properties. Let's go down the list and say yes or no. It's a potassium analog.
Yes.
Yes, that's why it works. It localizes in acute infarction.
No.
No.
No, it's excluded from infarction. Thallium only localizes in normal tissue, not in infarct. It's distributed proportional to relative blood flow. That is true. And therefore, A and C, correct answer would be choice D. Okay. The optimal time for detection of an acute infarction by technetium pyrophosphate or any infarct avid agent would be
E.
D like
D.
David, right. 24 to 72 hours. It takes at least 24 hours for the necrosis to take place. So before then, you'll get a false negative study. So what's considered the optimal time ranges is this, 24 to 72 or 1 to 3 days. Okay, here's a multi-part question. You, of course, would never get a question like this on your exam, but this is a great way to review. So I'll mention the mechanism on the left, and you could tell me which drug on the right employs that mechanism. Active transport.
E.
D, was that D?
Yes.
That is correct. I want to make sure there's nothing else. Oh, no, that looks like the only one. D, capillary blockage.
A.
A, phagocytosis.
F.
F, sulfur colloid. Remember, those particles are phagocytized by Kupffer cells in the RES. Compartmental localization.
E.
E.
That would be E, technetium red cells in the blood pool. Let me make sure there's not another one. I don't think so. Exchange diffusion.
B.
That would be B like boy. Sodium fluoride, F18, localizes in bone tissue. Remember, the fluoride exchanges with the hydroxide on hydroxyapatite. Sequestration, cell sequestration.
H.
H.
Damaged red cells. Metabolic trapping. I, good, FDG. Antigen antibody reaction.
C.
That would
G.
be prostacin, G. Prostacin is an antibody to a prostate membrane-specific antigen on prostate cancer. And the final one, somatostatin receptor binding.
C.
B.
That would, of course, be Octreoscan. Very good. And there they are. The ideal diagnostic radiopharmaceutical has a T effective of
D.
D. 1.5 times the duration of the test. All the others are totally wrong. Now, if this were therapeutic, that would not be the right answer. This is only applicable to a diagnostic drug. Okay. Which of the following would be a good reducing agent for technetium?
A.
A.
Right, stanocyan only. This one, stanic, has been oxidized to the highest form. It can't be a reducing agent anymore. So stanocyan is the only one. Okay. When T effective equals T biological, which one of those 5 statements is true?
B.
Was that B like boy?
Yes.
Good. Remember that when T effective equals one of them, that's going to be the short one. The other one, the longer one, is going to be infinitely long. So in this case, the physical half-life will be infinitely long. Choice B. And there's the little explanation for you. We analyze our technetium radiopharmaceuticals for impurities. These include
C.
D like David, free tech. Free tech is protectanate. We don't want it in MDP, for example. Hydrolyzed reduced is a colloid. We don't want that either. The other things are related to generator QC, but not radiopharmaceuticals. So the correct answer is choice D. Okay. Images of blood pool studies may be taken at what times post-injection? Can we do it in minutes?
Yes.
Yes. Can we do it in hours?
Yes.
Yes. Can we do it in weeks?
No.
No.
No. So A and B, and therefore choice D would be correct. Okay. Which of the following represents compartmental localization?
A.
A only, sure. These two are contain particles and they have totally different mechanisms. Okay. Let's match up the particle sizes. First of all, for sulfur colloid, is it ABC?
D.
Sulfur colloid is C, 0.1 to 2. MAA is
A.
A. By law, it has to be 10 to 90. MDP is
D.
D.
D. MDP is totally soluble. It has no particles at all. So 5 to 10 is not an answer to anything. And so the choices would be sulfur colloid. It would be C, A, and D. And there they are. Okay. Let's match up the number of MAA particles with the population that we're injecting. An adult without pulmonary hypertension.
B.
B, 350,000. An adult with pulmonary hypertension.
C.
D.
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 That would be D. That would be D. A 3-year-old child,
A.
C.
C.
the 3-year-old child would be C. Let's back up one step. Look at the neonate. The neonate is only going to get 50,000. That's the smallest number we can ever get. On a 3-year-old, we find out how much he weighs and we scale it up. So we're going to scale it up to around 100,000. Pulmonary hypertension patients, 150. Remember, we're walking a tightrope there. You go below 150,000 particles, you can get a blotchy looking scan that looks like COPD. On the other hand, if you go significantly above 150,000 particles, you can compromise the patient's safety by occluding too many blood vessels because vasoconstriction is going on. So that would be your answer. And here's a lengthy explanation of it. When you're reviewing for your exam, you'll have this in your lecture notes. Okay. All right. Let's match up the procedure with the adult dose. These are all adult doses. Bone scan would, and some of these can be used more than once. Bone scan would be
F.
F.
F, 15 to 25. Perfusion lung scan would be
C.
C.
C, 3 millicuries. Thyroid uptake test would be
A.
A.
E.
A, 200 microcuries. A liver scan would be
D.
D. We usually give 8, but 5 to 10 is the correct answer. Thyroid therapy for carcinoma,
G.
G.
that would be G like George. Therapy for carcinoma would be like 150 millicuries. A perfusion brain scan, which we really don't do very often, would
F.
be
F.
F right next to it. Again, 15 to 25. A gallium scan will always be
D.
D.
D, 5 to 10. Remember that rule. And a MUGA,
F.
that would be F again. So we had 3 of them that were F, and there are your answers. Okay, true or false? Now, you know, in true or false questions, you obviously have a 50% chance of getting it right. And still, some of them are really easy to miss. Let's take a look. These are all true, false, and they're all about HIDA studies, about mebrofenin and dizofenin. A, true or false? The typical injected dose is 1 millicurie.
False.
False. It's 3 to 8 based on what?
Wait. Or your
Bilirubin, not the body mass. That's the only time where we base it on bilirubin. B, in an emergency, you could substitute sulfur colloid for dizofenin.
False.
False. Sulfur colloid is never excreted into the gallbladder. Okay, C, if gallbladder accumulation first appears 90 minutes post-injection, that's normal.
False.
Totally false. Gallbladder emptying could be effected following administration of a glass of milk.
True.
True.
That's true if it's whole milk. Skim milk won't work. You need that fat to affect the gastric emptying, the gallbladder emptying. IDA, this is a nasty question, I know. IDA stands for imidodiacetate.
False.
That is false. Good. It's imino, I-M-I-N-O, imidodiacetate. The administration of IV morphine effectively empties the gallbladder.
False.
It helps the gallbladder to fill by contracting the sphincter of Oddi. The typical administered dose of 3 to 8 millicuries is based on body surface area. Right, we know that.
False.
That's false. Okay, and there is a very lengthy explanation for your review at another point in time. Let's take a look at some isotope energies. First one, if you missed this one, you got to go back to kindergarten.
E.
Magnesium,
D.
of course, E. Cobalt 57,
C.
C. You must know cobalt, by the way. They ask about that on exams all the time. 122. F18,
B.
B. 511. I-131,
F.
F.
F. Good. Thallium.
A.
A.
Now, thallium has, yes, the gamma rays are 71. It also has, erase that. The X-rays are 71. It has gamma rays of, I think, 135 and 167, but their percent abundance is very low. So mostly we're capturing these X-rays. I-123,
D.
D, 159. Very good. You thought you were through with long questions, but you know, one more to go. Pulmonary perfusion, what drug would we use?
G.
G.
G, Meckel's diverticulum.
B.
B.
B, bone marrow imaging.
M.
M, sulfur colloid. Blood pool imaging.
A.
A.
K, red cells. Abscesses and inflammatory sites. There are 2 answers to that.
A.
A or J.
Good. A and J. Hepatobiliary.
F. F.
F. Good. Glomerular filtration,
H.
H.
H, DTPA, tubular secretory function,
I.
I, MAG3, testicular torsion flow study,
B.
B. Now, actually, technetium, anything would work for a testicular torsion study. We always would use pertechnetate. There's one exception. What drug will never get to that part of the body? And that would be MAA. MAA goes to the right heart, to the lungs. It never gets to the left ventricle to be pumped out to the body. And MAA would never be used for a torsion study. A thyroid uptake test, what would we use? Two answers,
L.
N,
L,
L,
L and
B.
D, right? We rarely would use I-131, but we could. So L and D. Neuroblastoma, two answers.
C,
C,
N,
N.
C and N. Good, sure. MIBG and Arcrea scan and insulinoma.
N.
That's N only. That is a tumor that has somatostatin receptor sites, but it is not a neuroendocrine tumor. That's why MIBG doesn't work for it. Hepatic hemangioma.
K.
K,
K.
Good, K. That's a red cell scan. And hot nodule ablation.
D.
D.
D. Very good. That's the last really long question we have. What test animals were used for the original USP pyrogen test?
rabbits,
Rabbits. Good. The current test uses the horseshoe crab, which is Limulus polyphemus, is called the LAL test, Limulus amoebocyte lysate test. The rabbit test was done as follows. They gave a dose proportional to a human dose, and then they measured the rectal temperature on 3 rabbits at 3 different points in time and looked for elevation of temperature. And that's how it was done. And in some drugs today, it's still using that test because the LAL test doesn't work under all conditions. Like if it's very acidic or very basic, or if it's in a suspension, sometimes it just doesn't work. Okay, and then this describes the rabbit tests here. What advantages does the LAL test have over the rabbit test? Is it rapid? Yes, it takes about an hour. Relatively inexpensive, reasonably priced. Very sensitive, much better. It's probably 100 times as sensitive as the rabbit test. So the correct answer is D, all of the above. Okay. What fraction of the pulmonary capillaries is occluded by a typical dose of MAA? Now, be careful here. I'm asking the fraction, not the percent.
C.
C is the fraction. Which would be the percent?
A.
A.
A would be the percent. 0.1% is the same as a fraction of 0.001. But the question asks the fraction. Fraction is 0.001. If it had asked percent, it would have been choice A. Okay. The ideal particle size to use in humans for lung scanning is. Now, we remember what the, for MAA, the mandatory range is 10 to 90. This is not asking that. It's asking what is the ideal particle size? Which one is it?
B,
It has to be B because that's the only one that falls within 10 and 90. All the rest of them are outside of it. So the ideal particle size is really more like, yeah, it's 20, probably closer to 30 or 40. We want to be in the middle of the range, or the manufacturer wants to be in the middle of the range, because if he goes outside of the range, he might be throwing away 20,000 vials that he just made up that don't meet specifications. Okay. The ideal pharmaceutical for imaging studies has, let's go down the list here. You just say true or false. A T effective equal to 1.5 times the test duration. True or false? True. Remember, these are diagnostic imaging studies. In the absence of particulate radiation,
True.
true. We don't want alphas and betas. We want gammas. A gamma energy of 100 to 250,
True.
True.
and a decay by isomeric transition.
True.
True. So E, all of those are correct. Those are the 4 non-intuitive properties of the ideal diagnostic drug. The T effective of technetium 99M is
D.
that D like David?
Yes.
Correct. An isotope does not have a T effective. It only has one half-life. That's T physical. A compound has a T effective. If this had said, what is the effective half-life of technetium MAA, then there's an answer to that. But the isotope only has a physical half-life. It doesn't have a T effective. Until you know what compound, does it say that here? Until you know what compound you're dealing with, you don't know what T biological is, so it's impossible to have a T effective. Within what % of the prescribed dose must the calibrated dose be for a diagnostic drug?
C.
C, 20%. It used to be 10%, not anymore. The NRC changed that in 2006, and the correct answer is 20%, plus or minus. Okay, I think we only have 2 questions, so we're going to finish right on time. Prescribed dose of thallium for a particular patient is 2 millicuries. The technologist accidentally administered 3 millicuries. Now, that's a 50% overdose, right? You know that that's an event, but you can't determine until you take a look at radiation dose whether it's a reportable event or a recordable event. We know it's an event. Wrong drug, wrong dose, wrong route, that's an event. But look at this. The whole body dose was 3 rems, and no single organ picked up more than 5 rems. What was that? Is that an event reportable to the NRC? Is that an event reportable to the state? Is that an event reportable to both state and federal? Or that's not even a reportable event?
Not reportable?
Good, that is not reportable. Why is that? Because for a reportable event, if the whole body dose is greater than 5, or a single organ dose is greater than 50, that would make it reportable. I think that's on the slide here, yes. So this is a recordable event. Now, the technologist might be reprimanded because something happened that should not have happened, but it's not reportable, no matter how bad it sounds. So it's as long as the dose is less than 5R whole body, less than 50R single organ, that is recordable. The approximate distribution of sulfur colloid in the reticuloendothelial system is
D.
D.
D, 85, 10, and 5. And you will be happy to know we're almost at the end. What correctly characterizes hydrolyzed reduced technetium?
A.
C.
C.
I hear A and C and B. Okay, hydrolyzed reduced is a colloid. We don't want it because it's going to go to the liver and spleen. So if you have, let's say if you have 10% hydrolyzed reduced in your bone agent, you're going to get a liver spleen bone scan. That's not what you want. So keep in mind, this is a colloidal suspension. A bone scan reveals a bone to soft tissue ratio of 5:1 and a lesion to bone ratio of 5:1. What is the ratio of lesion to soft tissue?
D.
G.
D, 25:1. If you cross multiply these, bone over soft tissue times lesion over bone, bone cancels, you're going to get 25:1. What % of the injected dose of bone agent goes to bone, and what % is excreted through the kidneys?
B.
B,
B.
roughly, it's 45 to 50%, both in the bone and through the kidneys. Okay, and which of the 2 following patients would you expect to have difficulty in labeling their red cells? Let's go down the list. Patient who's undergoing chemotherapy. The answer is yes. Many chemotherapies interfere with red cell labeling. High dose antibiotic. No. Someone has received an injection of strontium. No. Patient who's been heparinized. That's a big problem. So there are special techniques you have to use if you have a heparinized patient. So A and D are big problems for labeling red cells. Okay, I'll tell you what, we're going to finish this test next time, unless you want to take another 10 minutes, up to you. You want to continue for 10 minutes?
You can continue.
Okay, let's do that. And then we'll have the whole time next time dedicated to the NRC stuff. And this is pretty quick. Okay, MAA localization in the lungs is based upon what?
D.
D, we are microembolizing capillaries. We're forming 350,000 miniature blood clots. It's not a problem because there are so many capillaries. There are billions of them. So yes, we're microembolizing. The uptake of MDP in bone tissue is based upon
B.
B, surface adsorption on hydroxyapatite crystals. FDG localizes in malignant tumors because C, it undergoes metabolic trapping. Why does indium labeled octreoscan localize in an insulinoma?
D.
D.
D, receptor binding, somatostatin receptor site. Airways in the lungs. Imaging those airways is an example of,
B.
D.
Compartmental.
C.
yeah, my intended answer was compartmental, but keep in mind that when you do that breath holding phase during the compartmental localization, some of it will diffuse across the membrane in the lung and get into the blood pool. So C was the answer I'm looking for, but B is the second mechanism associated with pulmonary ventilation. Imaging of tubular secretory function is an example of, now keep in mind that's MAG3.
D.
D.
That would be D. That happens to be the only renal agent that it undergoes active transport. Lengthy explanation there. Uptake of iodide by the thyroid is an example of
D.
D, active transport. Remember, it goes from mono to di to tri to tetra. Those are energy dependent steps. Okay. Transfer of xenon across membranes in the lungs and into the bloodstream is called
B.
B, simple diffusion. Sodium fluoride, why does that go to bone tissue? What's the mechanism?
D.
C, exchange diffusion. Remember that fluoride exchanges with the hydroxide. For visualization of prostate cancer, we use indium prostacin. What's the mechanism involved?
A.
A, this is an antibody. It's an antigen-antibody reaction. Which one of the following is not compartmental localization?
C.
That would be C. Actually, you probably could make a case for it, maybe, because it does fill up the gallbladder, but that was the answer I was looking for, hepatobiliary. Which of the following would be active transport? I think we've actually had most of this already. Iodide is a yes, MAG3 is a yes, and rubidium is a potassium analog, and that's also a yes. Those are all active transport. So choice E, all of the above. Which of these would be physicochemical adsorption?
B.
That would be B only. Bone agents binding to the hydroxyapatite structure of bone agents. Which of the following monovalent cations is a positron emitter?
B.
B.
B only, correct. For MAA, which one of the following statements is false? Let's go down the list. Typical injection in adults is 350,000. That's true. The number of particles is reduced in pulmonary hypertension. That's true. 1% of all capillaries is occluded.
False.
That's false. It's 0.1%, 1/10 of this. Biological half-life of MA in the lungs, about 8 hours. That is true. And we are done. So that only took about 5 minutes. We're going to be starting on this slide next Thursday. And I'm going to be suffering in the heat in Miami Beach next Thursday. And hopefully we won't have any electronic problems. I'm going to be taking my computer with me and it'll have this file on it. And you should be able to just log in with the same login that we always do. So any questions from, let me stop the screen sharing. Any questions from anyone at all who's logged in about anything that we have ever covered? Anybody? No? Okay, good. I will see you all next week. And again, thanks for your attention. Have a good week.
Thank you.
Thank
Bye.
you.
Thank you.
You.
See you soon.
Thank you.